Well, so a couple of things to talk about right now is number one, this whole issue of when will we peak? And we've been learning a lot, and we've been changing things, and we've been looking at different projections and different days, and it's almost like trying to predict the stock market, right? You input information, but then the information changes, and what happens changes. I would say that the one thing we're learning from a lot of the models, and I'm very happy about this, is that because of what's happening, because of social distancing, because of all the different things, the models look better than they initially suggested, and that to me is great news, because at the end of the day, we want less disease, not more disease. So if the models were going in the opposite direction, I would be very upset. But the fact is, the models are going in the right direction. We're seeing less disease. We're seeing less hospitalizations, and I think that's the result of public health working. We're doing social distancing. We're doing the right things. So in a way, is good to see the data looking that way, and let's keep on doing what we're doing. But at the end of the day, flattening the curve is the number one thing, because not only do we want to decrease transmissions, we also want to decrease the number of hospital admissions and the number of people that are needed for care in the ICU. I was talking this morning to colleagues of mine in France, and as you've seen, the mortality in France is about 10%. The mortality in the US about 3%. So they have about threefold the mortality we have here. And colleagues in France were telling me that that's what happens when your ICUs get overwhelmed. And it's not that they get overwhelmed just because you don't have enough beds or ventilators. We've been focusing way too much, or maybe you're right, but we've been focusing on beds and ventilators. But one thing we've learned here at Emory and in other places is that these patients take a lot of humans to take care of them. And for example, we're doing a technique called prone ventilation. And prone ventilation means that normally you keep the patients lying on their back when you have a tube and a ventilator attached to them. But with this disease, we've learned that you have to flip them in their abdomen and ventilate them with them flipped around. This is called prone ventilation. And then you have to rotate them and going back and forth like that frequently throughout the shift. And doing that requires enormous amounts of staff, of nurses and respiratory therapists to do that and to do it safely. But if you're able to do that, your mortality comes down when people are on a ventilator. And for example, here at Emory, we've seen a much lower mortality than what they've seen in Italy or in France. And talking to my colleagues this morning in Paris, they were saying, yeah, that's because we simply do not have enough staff in our ICUs to do the prone ventilation that you guys are doing. So again, I want to emphasize this is not just about ventilators and ICU beds. This is really also about humans, about staff. So I don't know if anybody has any questions about that.
All right, let's go to questions. You can start entering your questions into the chat function. Dr. Del Rio, can you see the questions there?
I'd rather have you read them for me.
Sure. So our first question is, some people are seeing long delays in getting test results, a week or more. What are the consequences of those delays? Why are they still occurring?
Well, I think there are several questions there. Number one, yes, we're still seeing delays in test results, and I'm worried about that, and we should not see that. Tests we're doing here at Emory, we can get your result within 24 hours or less. I think in public health, we're still seeing some delays. A lot of it is a throughput issue. You have to get the test done, you have to process it, you have to put it into the machine, you have to run it. But several days is clearly not acceptable. And delays translate into two things. At the hospital level, delays translate into PPE wasted, PPE used, right? If I have somebody in the hospital, I don't get the result, and they happen to be negative, and it takes 5 days to get the results. During those 5 days, I'm consuming personal protective equipment, and therefore I'm wasting it because that person didn't need it. So delaying test results translates into wasted PPE. But number two, it also translates into transmissions happening because we don't know if that person is infected or not. So we have to decrease the time. And I think critical to opening the country, and we talk a lot about this idea of opening the country, is going to be to have test results readily available. Not only should tests be accessible, but results need to be quick and available quickly to the individual and to public health.
All right, great. Let's move on. Why are African Americans becoming so affected with it?
I think there are several things there. I think I can think about three things. Number one, racial disparities in our country are a reality, and we need to again acknowledge that they exist, and we need to address them, and we need to address them effectively. Number two, why are there's racial disparities happening in this disease? Well, one may have to do with exposure, right? With if you live in poverty, you live in smaller spaces. And I tell people that, social distancing, shelter in place is a luxury, right? It's easy for me to shelter in place because I have a big house. We can be separated with my family and people living there. But if we had a 1-bedroom apartment and we had 4 people living there, it's very hard to separate and to be 6 feet apart. So there's a lot more. If one person in the household becomes infected, everybody in the household becomes infected. Number two, it has to do with diseases. We know there's higher prevalence of diabetes and hypertension in African Americans, and that's driving a lot of the complications of the disease. And number three, it has to do with community. It has to do with the fact that our African American communities, our Latino communities, our minorities do not have the same access to healthcare and do not have the same access to testing as other communities have. So we need to ensure, as we address these disparities, that we take testing to the communities so we can address we can test individuals before they get sick, before they need to come to the hospital, when they usually present with fairly advanced disease.
Okay, next question. How do you figure out you need to do prone ventilation, and why does it work?
Well, I'm not an ICU specialist, so I can't tell you. That's beyond my specialty knowledge. But I can tell you that our ICU colleagues are really excited about this. They know it's a better way to ventilate patients, and they are really doing a yeoman's job doing that. I would strongly suggest that at some point in time we have one of them on this briefing, because I would be talking outside my area of expertise.
Excellent. So next question. You're saying the numbers are looking better. Can you quantify that? The cases continue to increase in Georgia.
Yes, the cases continue to increase. But remember, part of the increase is transmission, but other part of the increase is more testing. As you test more individuals, cases are going to go up. And that's okay. We need to know the extent of the disease that we have in the state. But we know that cases are stabilizing because the number of hospital admissions is not going up as fast as we thought it was going to. And the number of ICU admissions is not going up as fast as we thought it was going to. So again, it's an issue. I'm looking at from the hospital. I'm looking for the clinic. We're not having our hospitals overwhelmed the way New York is having their hospitals overwhelmed. So to me, it's an issue of hospital admissions that is telling me that something is happening, that something is looking better.
All right, next question. Some have said that flattening the curve means that we will have to fight this disease and be socially isolated even longer. What does a longer outbreak mean for patients, mortality, hospitals?
Well, there are a couple of things that are true there. Yes, the disease will last for longer if we do this, but the mortality would be lower. Again, I mentioned the idea that if you overwhelm hospitals, mortality goes up. If you overwhelm hospitals, we know that from France, from Italy, from New York, if you overwhelm hospitals, your mortality is going to go up. So I'd rather have a steady state of patients coming that we can take care of than have, crisis and having our ICUs and your hospitals overwhelmed and then mortality going up. Number two, yes, we're going to fight it for longer periods of time. But as I said, if we scale up testing and we're able to identify people quickly, and we're able to then isolate individuals, and we're able to do contact tracing and make sure those contacts of that individual also get isolated and tested, we will be able to stop the outbreaks. I was talking to some people this morning and saying that to me, it's a little bit like addressing if I had a leak in my roof. I'd rather be dealing with a leak in which there's some drops of water coming in than having a hole in my roof where a whole bunch of water is coming in, right? It's a lot easier to deal with small, raindrops than it is to deal with a big, gush of water coming in. So detecting those raindrops as they're coming in and rapidly intervening is going to be a way. Public health is going to help us, but we need better testing. We need access to testing, and we need rapid results, which is exactly what your first question was about.
Next question. When will antibody tests be available?
Yeah, that's a really good question. I know colleagues here at Emory are working very, very hard they have developed what we call a laboratory developed test to detect antibodies, and they're working very hard to validate the test and to hopefully start using the test in the next couple of weeks. Other companies are doing the same. Now, having an antibody test is going to help us to identify who has had the disease and is going to give us another option for testing, very much like for having an HIV test or a hepatitis test or other tests that detect antibodies. So when will it be available? Hopefully in the next couple of weeks, I think we'll have one or more antibody tests out there in the market.
Next question. What is the reason we hear about people who had coronavirus and recovering and then testing positive again? Does it return?
Well, again, we don't know if those people are recovered or not. We don't know if those people are reinfected or not. And just because you have antibodies doesn't necessarily mean you have immunity. So we need to understand immunity. We need to understand what immunity looks like. And like in any disease, immunity is not going to be perfect. Some people are going to get infected and not develop immunity. Immunity is not 100%. Even with a vaccine, it's not 100%. So I'm not surprised that there's going to be cases of reinfection, but it's not going to be everybody.
All right. Earlier this week, IHME's estimate for the peak moved up a couple days. Hospital resources went down, but the projected death toll went up and has gone down only slightly. Your thoughts on this change? Any reason?
You know, it's modeling. You change one parameter and things change. So I cannot give you the exact reason for this. First of all, I'm happy to see that the hospital utilization is not as big as we initially thought. So I like that. The mortality, I still think it's a little overstated. But again, I'm not going to fight with them because they're obviously the IHME people are incredible modelers, and I've been talking to them, and again, I think they're overestimated their mortality. Several of us have told them that, but they stand from their models, and I cannot argue with them because again, their expertise is in that. But I think my gut feeling is their model is overstating mortality because they're using inputs from other places, and I think the mortality we're seeing in the U.S. is lower than in other places.
Okay. Do you still expect peak day in the US to be on Easter Sunday?
You know, probably, but it may be plus minus, 3-4 days.
All right. How long can the virus remain on my clothes, shoes, and food containers?
The virus can remain for a couple minutes in materials. I think it remains the longest in metals and in cardboard. I worry less about food containers. I worry more about your pizza box. But having said that, again, if you wash your hands, if you use water and soap, the virus goes away. This virus needs to cell. It's not, the virus is not there by itself. It's there with secretions, with cells. And as long as you use soap and water, the virus will go away.
Right, next question. A variety of different tests are being advertised online and locally. How can people verify what is being approved by the FDA's emergency declaration and what could not be legitimate?
There's a website that the FDA has where the testing are, and I agree with you. It's crazy, and we need to be looking at exactly what is out there because it's so many things. I was hearing from my son who lives in Miami that there was individuals going to households and offering, a test for $75, and the test is totally legitimate. So there's a lot of scams happening, and we need to be careful about those.
Okay, because Georgia was so slow to adopt mandatory statewide social distancing, will we lag behind the rest of the nation in reaching peak?
I don't know. I don't know. I remember most of 50% of Georgia is Atlanta, and Atlanta did shelter in place a lot sooner, about 7 to 10 days sooner. So Georgia is not one place; it's multiple places, and I think each place will be different outbreaks. And the dates, the date for the state is just an average of everything else that is happening.
With Governor Kemp extending the stay-at-home order through the end of the month, is that long enough?
I don't know. We'll know near the end of the month. And again, he's very open to continue it. He's very open to listen to public health. So, let's wait and see where we are near the end of the month. I think around the 20th, we'll start having some discussions of seeing where we are. We're going to be supposedly past the peak, and we'll be able to make better predictions.
Even after we hit a peak, until there is a vaccine, will there be a time when we can return to a more normal life? Can we
You know, I
safely have large gatherings such as sporting events, church, movies, school before a vaccine?
I don't know. I would love to get back to a normal. We're going to have a normal, but it may not be the normal we knew before. It's going to be a different normal. I would be reluctant to go to a huge event like $100,000 100,000 people, football event may not be where I go to, but maybe going to a church event that has, 50, 100 people may be okay. Maybe we need to not let people that are vulnerable, people over 65 and with chronic conditions, go to those events, but younger people will be okay. Maybe we need to encourage people to use masks at those events. So I think the new normal is going to be a different normal, but believe me, we all want to get back to normal. As I tell people, I want my job back. I really want to be back doing what I normally do.
The state says it's not tracking the number of healthcare workers becoming infected. Is that something that should be tracked, especially with possible staff shortages?
As far as I know, healthcare systems are carefully tracking the number of infected healthcare workers, and we have that information. We're looking at it carefully. I can tell you, it's not that many in our healthcare systems. We're tracking it carefully for two reasons. Number one, because we're worried about staffing, but number two, because we also want to be able to provide the support that the staff needs in case they need, emotional support, physical support, and other support. So healthcare systems are tracking that very carefully.
How long would you recommend wearing a surgical mask? Can I clean and re-wear it?
If it's one of those disposable masks, yes, as long as it's not dirty, you can wear it. I've seen people. I wear mine for about a week, and then change it. If it's a cloth mask, you can wash it and you can use it as many times as you need. And probably washing it every 3 to 4 to 5 days is going to be fine. Again, the part of the mask that is going to get dirty mostly is going to be inside, where your spit and your saliva is attaching to.
Can pets contract COVID-19?
That's a question that comes up all the time. Pets, there's certain coronavirus, a lot of coronaviruses infect cats and dogs. So we think that some of them may be infected, and we know, but studies that have been done have not shown infection of the animals, of pets. There is, of course, you saw the Bronx Zoo, a tiger got infected. I have no idea who was the brave person that went and did a swab in that tiger, but obviously the tiger is doing fine. So pets tend to have coronaviruses, and they do fine with them. Some cats get diarrhea and other diseases, but I don't think COVID has been known to infect animals at a large scale.
There's been some talk about a connection between countries where tuberculosis tests are mandatory and lower infection rates. There's a study currently underway to learn more. Explain the potential correlation.
I do not understand the correlation, other than to say that maybe, and it's not tuberculosis, it's administering the BCG vaccine. It's a vaccine that is used for tuberculosis around the world. It's not a very effective vaccine. It prevents disseminated miliary tuberculosis, that it's a problem in developing countries, but it's not a problem in a country like ours. So we developed countries tend not to use the BCG vaccine, but it is actually the most commonly administered vaccine worldwide, because all developing countries use it. It's given at the time of birth. And there's some evidence that some correlation that having BCG vaccination decreases your risk of infection. But we don't know if it's a BCG vaccination or something else. And there are some studies happening. It may have to do with priming your immune system early on.
What do you think peak day will look like here in Atlanta?
I think it'll be sunny and 75 degrees. I don't know what's going to look like. I mean, I just hope it's not going to be, I think the hospitals are not, hopefully they're not going to be overwhelmed. We're all preparing and we're all on call and ready to go respond to the hospital. But my hope is that it's not going to be a crazy day in which we're going to be having a lot of patients going to the hospital. But again, I cannot predict what it's going to look like. It's just trying to predict. We just need to be prepared for it. And as I said, all the hospitals are prepared. We have people on call. We have people on backup call, and we're ready to be there if it's necessary. But it's a matter of being, it's a matter of waiting for a hurricane to hit you. It may hit you with a Category 4. It may hit you with a tropical storm.
At this point in the outbreak, what worries you most in the near future?
What worries me most is two things. I worry about the economy, because I worry about people losing jobs. We have a huge unemployment already. I worry about people, you know, losing their jobs. I worry about people uh, emotional health. I worry about people getting depressed because they lost their jobs, because they lost loved ones from the disease. I worry about the our healthcare workers' mental health. They're very stressed. They're working very hard. So what worries me is the consequences. It worries me those other issues, and I think as much as possible we need to try to return normalcy to our lives. And as I say, I don't like the term social distancing. I like the term physical distancing. I want to continue to be socially connected. This morning, I was texting my kids. One of them lives in Connecticut. The other one lives in Miami. And we were saying, let's get together for Christmas brunch. A virtual Christmas brunch will be great. And we're going to do that. We need to figure out how to remain socially connected and how to try to have normalcy back in our lives.
Do you believe there will be a second wave of this virus?
I don't know. There may very well be, but again, I don't like to make predictions. They're very hard. But what I do know is that we're working on vaccines, and we will have vaccines and we will have therapies. And I think the advances being done through research in developing vaccines and therapeutics are going to change if we get hit by a second or a third or fourth wave of this virus. So the second wave or the third wave or the fourth wave is going to look very different than the first wave, simply because we're going to be better prepared and we're going to have better tools available to us.
You said hospitalization rates are lower than expected. What was expected and what are we seeing?
Well, we were expecting exponential growth and we're seeing linear growth. So, that's a big difference. Instead of seeing one day 10 patients and the next day 20 and the next day 40 and the next day 80, we're seeing one day 10 and the next day 12 and the next day 14 and the next day 16. That makes a huge difference.
What can families living in the same home with an elderly family member do to protect them?
They need to not get infected. They need to remain uninfected. They need to practice social distancing. I know a case of somebody, in their 30s who got infected. And the only reason the person knew was infected is that person one day developed a fever, no other symptoms. And because of the fever, that person rapidly isolated themselves and then went, a couple days later, got tested and was found to be positive. But because that person rapidly isolated themselves and made sure they didn't infect the grandparents that live in that house, the grandparents are doing fine. Had that person not isolated themselves, then those grandparents could possibly be infected and be in the hospital right now. So be alert of any symptoms you have, anything different. You lose your sense of smell, you have a fever, you have a cough, you need to isolate yourself right away so you don't infect other members of your household.
Have French doctors offered any beneficial advice for helping our numbers, things that you will implement or try here?
Uh, again, they said simply please, do as much as you can to flatten your curve because you don't want to overwhelm your ICUs.